Hello, everybody, and welcome to this week's edition of It's Worth a Shot. Kyla Newland coming to you from a snowy Alaska. Today, our topics are going to be engaging patients in dietary adherence and anticoagulant use in long-term care settings. So we can go to the next slide. As always, we do have outside speakers that present on this series, and that doesn't necessarily mean that we're promoting or primarily promoting one service over another. So just having that disclaimer in here. We can go to the next slide. And happy holidays from everyone at Mountain Pacific. We're going to have a snowy Christmas here in Alaska. And I know some of you in the other states haven't gotten a lot of snow yet, but maybe you will and have that snowy white Christmas. We appreciate your partnership and just want to take this time of year to say thank you. We can go to the next slide, please. So last week we had a polling question, and the polling question was asking about if you needed a special DEA license or a waiver to prescribe buprenorphine for opioid use disorder. And the answer to that question is no, you do not as a prescriber. That requirement was removed earlier in 2023. And so any provider that has a DEA license to prescribe a Schedule III controlled substance can treat patients for opioid use disorder. And there's also no limit to the number of patients they can treat. Previously, there was a cap on the number of patients. So just passing along that information so that providers are able to treat these patients. And I did want to just dispel another misconception that I've seen is the fact that Suboxone, which is the brand name of buprenorphine with naloxone combo, is the preferred treatment for opioid use disorder. But the only active component of that medication is going to be the buprenorphine component. It is administered orally, and you dissolve it in your mouth, and the naloxone has no pharmacologic activity when it is given orally. So it was put in that medication as an abuse deterrent, actually, in case folks decided to abuse it and do things like inject it or administer it nasally. So just a little caveat there. If you hear it referred to Suboxone sometimes and buprenorphine sometimes, but essentially it's just buprenorphine is the medication that treats opioid use disorder. And now I think I'm going to turn it over to Callie for our updates for flu and COVID.
Okay, before we get started with that, just as a reminder, we appreciate you guys' topics and your feedback. So please keep sending us those ideas you have for upcoming It's Worth a Shot presentations. And we will continue to meet every Wednesday, except for next Wednesday. We're going to take a pause for the holiday. So we do have a quick polling question. So let's go ahead and do that now. All right. So coming up on the holiday, what is your New Year's resolution? I'm going to give you guys a couple minutes or a couple of seconds to fill this out. And I can't wait to see you guys' answers in the chat. Okay, a couple still coming in. All of the above. Those are good answers. I should have added that one. I didn't even think about it. So a couple of you guys said that. All right, let's go ahead and end that poll and share the results. It looks like a majority of you guys, or most of you guys, are looking at improving fitness, and again, all of the above. I love that. So let's stop sharing. Let's go ahead and go to the next slide. Okay, so for our quick influenza snapshot, unfortunately for Wyoming, we are full in the red. and experiencing some pretty substantial influenza outbreaks for the season. It looks like our other partner states, Montana, Alaska, and Hawaii, are in the green or light green, so a little bit more stable. Overall, there has been an increase in the illness and increase in hospitalizations. So not too late to get your flu shot. So let's go ahead and go to the next one. And for our COVID outbreak or COVID snapshot, again, still seeing some increase in trends overall. For the northwest corner of Wyoming and for the Big Island of Hawaii, there's been a substantial increase, and then some spots on the border of Montana and Canada, there's some substantial increases in our COVID rates. So same thing, not too late to get your COVID vaccines. And all right, let's go ahead and go to the next slide. And I would like to introduce Mark Nielsen. He is a registered dietitian coming to you guys from the great state of Wyoming. And we're happy to have Mark present today.
Thank you, Callie. So hello, everyone. Like Callie said, my name is Mark Nielsen, and I'm the registered dietitian for the Wyoming State Hospital, which is the state psychiatric hospital. And we usually hang around a census of about 80 patients. Today, I'm going to be talking about enhancing client engagement with food service and improving dietary adherence with our clients and patients. And I'll be using the terms patients and clients pretty interchangeably throughout the presentation, since we all come from different backgrounds and some of us may prefer to call them clients and others may be working with patients. Next slide. So we know that successful outcomes for patients are reliant on both patient and providers alike, and that the more engaged a patient is in their own healthcare, the better their health is likely to be. Improvement in care requires an approach that incorporates patient, provider, and system level interventions. And this is especially true for nutrition care because taste and preference of food greatly varies between households, ethnicities, dietary restrictions, and even religious beliefs. So giving patients a voice to suggest change and adjust and alter meal plan options to best suit the client needs can help improve nutritional outcomes and adherence. Next slide. And there's quite a few ways to engage clients in their nutrition care and in food service choices. And I'll just talk about a few that have been successful for us here at the Wyoming State Hospital. The first strategy is to simplify diet information and educate clients. So many clients that we serve may have minimal nutrition education or have heard of hundreds of different health tips from the media and aren't sure how to decipher all of the information. If we add to that information overload, then a lot of what we say is probably just going to go in one ear and out the other. So instead, we should find out what's important to our clients and their nutrition care and focus on that with simple, actionable information. We can also involve clients in menu decisions, and that can help create engagement. This can be done through surveys where you can gather information on client likes and dislikes on the current menu, or something we've done is our snack list and change options based on client input. Offering personalized menu options also helps patients feel as though they have a choice in menu decisions. Cooking classes or cooking groups can be another great way to include clients in food preparation, as well as allowing them to try new menu items before they're added. And lastly, tray evaluations. So many of the times we'll do tray evaluations ourselves, which is great, if we're doing them back in the kitchen. But another really powerful tool is actually having our clients fill out their own tray evaluations to give us feedback on the temperature, portion size, taste, texture, and overall quality of food from their perspective. So improving client engagement through some of these strategies can also help with something that's really vitally important in care, and that's adherence to prescribed diets. Next slide, please. So engagement and adherence go hand in hand, and there's many reasons for low dietary adherence. Demographic factors such as ethnicity, cultural preferences, socioeconomic status, education level, all of these have been associated with affecting dietary adherence. There can also be psychological factors like health beliefs, perceived seriousness of the disease that they may be combating, vulnerability to complications, efficacy of treatment. All of these can also affect adherence. Social factors, so family relationships can play an important role, as well as the availability of support from healthcare providers and the medical system. There can also be disease and treatment related factors, so lower adherence may be expected when a health condition is chronic, when the symptoms aren't apparent, and when a regimen is more complex, and when treatment requires lifestyle change. And finally, and perhaps most importantly, the quality of food. The quality of food is really going to affect patient adherence in a hospital or clinical setting. If the food is bland or unappetizing and doesn't take into consideration client preferences, then they're much less likely to adhere to their diet. Next slide, please. So there is good news, and the good news is that we can have a direct effect in improving dietary adherence from our actions and how we treat clients. Some of the things that we want to do are customizing our nutrition recommendations and diets to each specific client's motivation. We want to educate clients. Improving client dietary knowledge will help improve adherence. We want to allow flexibility for patient preference and personalized menu choices. We want to follow up with patients, and we want to do this frequently to see how their diet is going and make changes based on this. We want to set goals or weekly action plans and aim for small, realistic goals that patients are confident that they can achieve. And we want to create engagement. So we want to give patients the options to give input on meals and snacks served through surveys or even involving family members in the support process. So now to wrap up, we're going to take a quick look at a client scenario and determine what may be some beneficial strategies to increase the specific client's diet adherence and improve their outcomes. Next slide, please. So this is just a quick look of a typical person we may see and determine how we might best improve their adherence to nutrition and diet recommendations. So Lucy is interested in losing weight after a recent diagnosis of type 2 diabetes and hyperlipidemia. She has never had any diet education in the past, but she has tried several different diets after hearing about them, and these include the Atkins diet, intermittent fasting, and the South Beach diet, and she lasted around a week on each diet before deciding it wasn't working. So the patient is now interested in following a strict ketogenic diet. So take a minute to think about the following questions. So what are some concerns about Lucy's dietary habits and dieting habits? Would a ketogenic diet be likely to be adhered to based on Lucy's dieting past? And what may be effective strategies for this client to increase dietary adherence? So take a minute, think about these questions, and then we're going to loop back and talk about them. Okay, so looking at these questions, what are some concerns about Lucy's dieting habits? So Lucy has not been able to stick to a diet. So she's wanted instant results and has swapped diets quickly once results didn't come, within a week or so. Would a ketogenic diet be likely to be adhered to based on Lucy's dieting past? While a ketogenic diet can work well for many people, Lucy has a track record of not being able to stick to a strict diet. And there are other ways for her to be successful in her weight loss goals and type 2 diabetes management that she's more likely to adhere to. So what may be effective strategies for this client to increase dietary adherence? And everyone may have different strategies, some of the ones I can think of. So educate Lucy. She has no history of nutrition education, and even basic nutrition counseling can put her on the right path. Allow flexibility with Lucy. So she has tried and failed at following several very strict diets. So a more flexible diet that's customized to her preferences and not just something she's told to do or told to follow is a lot more likely to be adhered to. And then set goals with Lucy. So she mentions weight loss as a goal, but talk with her and figure out more actionable items. So weight loss would be the result of more actionable items that she can try to focus on. So while this is a quick and simple case study, it does show steps that can be taken to increase diet adherence with clients. And several of these things can be helped with by different members of the treatment team, not just those solely involved on the nutrition side. So like myself, a dietitian, it can be helped with by all members of the treatment team. So that ends my time. I'll stick around, and I think I am turning it over to Kyla. So thank you, everyone.
Yeah, thank you so much. That was great, Mark. So switching gears just a little bit here, we're going to talk about anticoagulants. So we can go to the next slide. So if you look at the National Drug Action Plan and look at medications that are kind of heavy hitters as far as causing adverse drug events, anticoagulants is one of these top 3. So this is one of the areas that Mountain Pacific is working to help support folks on looking at their anticoagulant use. We can go to the next slide. So this is some data from Medicare nursing home residents looking at adverse drug events for the year of 2022. And as you can see here, the anticoagulant-associated ADEs are actually really high, even when compared to the other 2 drug classes. And so this just reiterates the fact that we have work to do in this area. Go to the next slide. So this is a study that's just looking at the incidence of not specifically adverse drug events, but just adverse events in nursing home residents. And if you look at patients in the nursing home, 1 in 3 will have one of these events in their first 35 days of their skilled stay. And they estimate that about 60% of these were preventable. And as you'll see on the next slide, another study looked at how many events were preventable as well. And this was looking in patients that were transitioning from the hospital back to the nursing home, and it's estimated that 70% of these are preventable. We can go to the next slide. So this is a CMS list basically of potentially preventable events related specifically to medication. And if you'll notice, number 4 and number 5 are both related to the use of an antithrombotic or anticoagulant medication. We can go to the next slide. So I'm only going to be talking about the oral anticoagulants today. I'm not going to be talking about any of the injectable ones, just in the interest of time. And the fact that most patients that are being treated are using an oral agent if they're being treated long-term for prevention of clotting, basically, and those type of events. So our standard medication that's been around forever, warfarin, and its mechanism of action there, practice has changed in the last 10 years. And we've really switched over to these other class of medications. They're called the direct oral anticoagulants, or the DOACs. Sometimes you'll also hear them referred to as the NOACs, or new oral anticoagulants. So that can get a little bit confusing. And they do have a different mechanism of action than warfarin, and much less monitoring and much less dietary restrictions, which has made them really a preferred treatment. We can go to the next slide. So this was a study just briefly looking at kind of the transition of patients being on these newer agents. And the guidelines actually do preferentially recommend these drugs over warfarin if we're looking at stroke prevention. And our number one diagnosis for that is going to be atrial fibrillation. And I thought it was interesting as well that they found that 1 in 3 patients that had AFib were not on an oral anticoagulant. So we're putting these patients at risk of having an adverse event by not treating them with drug therapy versus treating them with drug therapy, which was interesting. So we can go to the next slide. I'm actually going to share my screen if I can here. And I'm going to show you a nice chart. I don't have it up. Miranda, would you be able to put that in the chat, the link in the chat, so I can click on it? Sorry, I had it up here and then I think I got something else and that screen went away. So anyways, it's a very nice chart for reference. It's got the dosing of each of the medications. It's got the indications that they're approved for. It's got contraindications, monitoring. It even has a picture. Thank you, Miranda. There we go. So this would be a nice thing you could hang up in your practice or your facility, just so that folks kind of have a clear picture of how these medications compare and what the appropriate indications are. And then also there can be different dosing recommendations based on the indication, and also different durations of therapy. And also, if patients have any kind of kidney dysfunction, you do need to dose adjust the direct oral anticoagulants. So just something to think about, and you can check out that link and maybe print that out. I really think it's a nice visual. Okay, we can go back to the slides. And we can go to the next slide. Perfect. So this was just a study looking at bleed risk with DOACs versus warfarin. And for the most part, we're seeing that they have a lower risk of bleeding, but as they've been on the market for a period of time, there is still this risk of bleeding. And if they're being dosed too high, we're putting patients at risk of a bleed. If they're dosed too low, we're putting patients at risk of whatever we're trying to prevent as far as an event. So still need to be diligent about monitoring these medications. We can go to the next slide. This was a study that I just wanted to mention that looked at patients that had a diagnosis of atrial fibrillation. And it basically looked at the risk at the end of life for these patients who had advanced dementia, and if using anticoagulation therapy was a benefit or a risk. And basically they found that by using them in this specific patient population, they had an increased risk of elevated bleeding, which was not worth the benefit, essentially. So just something to keep in mind with those patients that might be in that situation. We can go to the next slide. Just looking at that risk-benefit profile as we do with all medications. So these are some nice tools. I know that we've been distributing some of these to some of you folks. The trigger tool, which will help you kind of look at risk factors for patients, to what the risk is of having an adverse drug event related to all 3 of the drug classes actually, and then looking at other things that can put them at risk, including drug interactions, and other factors to consider, other medications that might be putting them at higher risk of bleed that we might need to keep in mind. And on the last slide, I have some tools for, oh, nope. This is a very nice opioid stewardship kind of platform or guide. So we've all kind of heard about or seen antimicrobial stewardship, and now folks are starting to do opioid stewardship. So the newest kind of stewardship programs that we're seeing are anticoagulation stewardship, and this is really kind of a really nice guide to if you do want to develop an opioid stewardship program and how you would go about doing that. And then on the last slide, I have some drug interaction tools that can be helpful. Also checklists on what to look for when you're looking at a patient that's on one of these direct oral anticoagulants. And then Mountain Pacific developed some tools for management of bruises, cuts, and nosebleeds if it's appropriate for a patient to be just treated for that and has been evaluated that no other interventions are needed. And those can be a nice guide for patients and for providers. And I think that's all I have. And I think I stayed on time too. Okay, yeah, Callie, thank you. She said those resources were sent out in the weekly updates. Does anybody have any questions? I'm curious if folks would be wanting further information, like maybe walking through the trigger tool, maybe at one of our sessions, and then also maybe looking at the anticoagulant stewardship program guide, if that would be helpful. Just let us know. Yes, Jolene, to answer your questions, are nursing homes going to be seeing more use of DOACs as an alternative medication treatment? I would say yes. I would say that it probably depends on the provider, and like maybe they've always used warfarin and they're maybe an older provider and they haven't really switched over to using the new ones, but they are used very frequently, and I think they'll just continue to be because of the lack of having to do the lab work and worrying about your dietary restrictions, and drug interactions are actually less with the DOACs versus warfarin, just based on the metabolism system that they go through. So you still have to look at drug interactions, but there are going to be less. Does that answer your question, Jolene?
Yeah, yes, it does. Thank you.
Okay.
It'd be interesting to see, you know, in the nursing home, their plans in moving towards this alternative treatment. It sounds exciting, you know, for the residents who are on anticoagulants, and now that there's an alternative treatment that may have less drug interactions.
Yeah.
So, yeah. Thanks, Kyla. Appreciate it.
Yeah, absolutely.
So I think that's about it. If we don't have any more questions, we can go to the next slide, Mary. And we just want to remind everybody that we are taking a pause next week. So there will be no It's Worth a Shot on Wednesday, the 27th. We wish all of you guys a happy holidays. And we would very much like for you to join us in 2 weeks, Wednesday, January 3rd in 2024 for our presentation, which will be on facility resolutions and our staff training tracking tool. And then just a little bit of a push on January 10th, that will actually be our 100th episode of It's Worth a Shot. So we'd definitely like you guys to join us for that. Jesse Kenzie will be joining us again, who actually helped originate It's Worth a Shot series. So again, happy holidays to you and your family. And thank you for joining us. And we hope you have a happy new year.